Hello everyone, I'm Dr. Aparna, Clinical Director of Neonatology from Cuddles, Kondapur, Hyderabad.
I am Dr. Shilpi Reddy, Clinical Director, Cuddles, Kondapur, and I am an obstetrician talking with a neonatologist.
So, what are we going to talk about today? Today is World Prematurity Day. Every November 17th is observed as the World Prematurity Day, and hence we both are going to discuss about prematurity, what are the risk factors, how to prevent prematurity, can we prevent prematurity, what are the trends in preterm birth rates, and what all we do as obstetricians, as neonatologists in managing these pregnancies and these babies.
Little babies with no noise, no voice, but they are the source of the next generation. It's our duty to take care of them and save those precious lives wherever possible.
So, ma'am, globally, it is said that around 15% of births can end up in a preterm delivery. So, in your experience, and ma'am has vast experience in dealing a lot of high-risk pregnancies, how do you see these trends going today? Are prematurity rate increasing? Are they the same? Are they coming down?
If I have to say about prematurity, I've started my career at around 2001 and this is 2025 right now. I have almost seen triple the rates of prematurity in practice. If we have to talk something in about 100 deliveries, we used to see premature deliveries less than say around 5. But now again, when it comes to the current prematurity rates that we are seeing, they are very, very alarming. And when we talk about prematurity, it is not only about, early premature babies. There is a late prematurity component also which is rising tremendously. And it is right now more than 15% in the current practice that I am doing. And this trend is just not warranted, just not wanted, but to a point that I have to say that prematurity cannot be prevented as such because there are so many aspects to it. It is not only about multiple pregnancy. If we decrease the number of multiple pregnancies, we might have lesser prematurity. Or it is the number of fertility pregnancies that if we decrease, the prematurity will decrease. We are seeing a lot of aspect of abnormalities in the uterus also, which sometimes can lead to prematurity. Diabetes, hypertension, higher order mothers, and lot of obesity that is causing havoc. So at times I feel that we cannot avoid certain things. To balance, lifestyle is the most difficult thing right now.
Absolutely.
So if you want something at the cost of something, that we are having an increased risk of prematurity, and that choice has been taken with all the knowing everything, they are taking that choice.
Right.
Because women know that they are crossing 30. Women know that their egg quality is going down with the lifestyle that they are in. Women know that they are obese. Women know they have PCOD. Women know that they have to go for fertility treatments. Yet, knowing all this, they are not able to accept prematurity. It is just happening.
Right. So again, as a neonatologist, what we see is, as Madam rightly said, this late preterm component. Generally, we know that a pregnancy is considered to be full term if it is somewhere between 37 to 40 weeks of pregnancy. So anything where pregnancy is having to be terminated less than 37 weeks, so the baby has to be delivered less than 37 weeks, we do call premature. But even in that group, in that broad category, 34 to 37 weeks late preterm births, as you said,
yes,
they are also vulnerable to a lot of problems.
Yes.
RDS, they have breathing difficulty, they may have relatively immature myelination of the brain, so they do take long time to establish good feeding, sucking skills even after they are born. And of course, babies who are born more premature, they need more extensive care at birth, but we'll discuss about all that in a little bit more detail. So, as obstetricians and we as neonatologists, we always say that there are some predictors or there are some signs during pregnancy which may indicate a little bit higher chance of prematurity.
Yes.
And it's particularly important to recognize these mothers because they are at the most appropriate care in a tertiary center like our center, where we have holistic support of OBG, of neonatology, of other disciplines like cardiology, anesthesia that these mothers might require. So, what are all those mothers where you would definitely want them to be in follow up of a tertiary center or a center with multidisciplinary holistic care?
For every mother out there who's pregnant, and there are so many women who are planning pregnancies, I would always tell them, in the current situation, current situation is so alarming that people are just sitting at their desk and collapsing. And we don't know certain reasons why there is a problem in blood circulation and perfusion. This is one aspect that it's really shocking to understand, that a person is going to office or going to work or dancing or something like that and they're just collapsing. So there is some problem, whether it is clot formation or whether it is inefficiency to perfuse or some acute conditions that are causing these kind of problems. And now similar kind of problems can actually happen in pregnancy also, unknown conditions, yet to be found out conditions. So what I say is, for every woman out there who can take care of themselves with their own decisions, do not delay pregnancies. That is something that I request, because young mothers have less vulnerability for complications. And also, when you're really looking at pregnancy care and everything, book at centers that have got all the facilities, especially high risk pregnancy, neonatology, then physician support, cardiology support, 24/7 anesthesia support, blood bank support, and allied specialties if you have any problems, like if you have a thyroid, an endocrinologist sitting there. All these things are very, very important. And certain things are really more important than all of this is a fetal medicine team. It is important to identify problems. We keep telling about women to have at least folic acid before you plan pregnancy, antioxidants before you plan pregnancy, correct your vitamin D levels, and also correct male factor issues by taking care of their tests and everything, and taking vitamins even for sperm health. So your pregnancies will be good quality, and young mothers have less vulnerability. Not only this, when you book early, you have a good fetal medicine team, you can actually know the problems of the body, and is the placenta good. At 12 week itself, NT scan reveals how good the placenta is, and we have markers to support that. Now that we have first trimester quadruple marker with PA, PP and PLGF coming into the loop, we can actually predict the chances of preeclampsia, hypertension in pregnancy, smaller baby risk. So checking the cervical length and amalgamating into the softwares that are given through Astria and Viewpoint and all these softwares, you can know whether you can have a preterm delivery also, especially measuring the cervical length at the right time and following up. And not only this, there are so many infections that we can screen when you come to a proper center. Urine cultures are important, vaginal swab cultures are important just to prevent prematurity. And higher weight women, please lose weight before you plan pregnancy. Make your BMI somewhere nearby to 25-30, 25 to 26, because any BMI that is above 30 has a component of diabetes, has a component of preeclampsia. And even we are seeing that rise in 27, 28, 29 BMIs also. So the apt BMI is less than 25, 26.
Right.
That is very, very important. So considering so many factors in front of our eyes that can actually prevent preterm, but they have been ignored for various reasons. Maybe they feel that they have already reached a higher age, they need not lose weight and get pregnant. Or they have a family history of sugars, yet they are not controlling their diet. They have every opportunity to come to a bigger center, yet they go to smaller clinics and waste their time around the NT scan time, where NTs are not done properly. markers are not done properly, risk identification is just not done. A simple 1 rupee, ecosprin tablet, low dose aspirin tablet,
Yeah.
can save them from a lot of preeclampsias.
Right.
Yet if it is missed,
Yeah.
you come directly for a TIFA scan and you've missed the low dose aspirin, that's done.
Yep.
They will land into prematurity with a component of preeclampsia. So there are so many things out there to talk about and to send information into the community, but it's really hard to adapt them. There is a lapse between information and application.
Right.
And that lapse is continuously increasing preterm delivery rates. I feel so bad at times that I have to deliver a woman, say around 36, 37 weeks, only because the placentas have given up. You know, the cerebroplacental ratios are bad. Sometimes there is no movement, sometimes there is more water, no water, less weight, more weight. So I feel I hardly see any normal reports nowadays.
Right. So, from our perspective, ma'am, there are also certain things that we would love the families to have got primed for when sometimes we are seeing them for a prenatal counseling. So, as you said, there are a lot of things that can be done during the pregnancy.
Yes.
But when we are eventually faced with a situation where we are anticipating a sort of high risk delivery, we certainly look forward to certain things, and we are very glad that at our center, at our unit, these happen like a protocol. One is antenatal steroids. So, although we have discussed so many factors that can be done proactively to prevent preterm births, there are some things, some good practices that one should know, one should be aware of. If at all there is a situation that for various unavoidable reasons, if there is a situation where the baby has to be delivered preterm, there are some good practices that can tremendously impact the outcome of the babies, and our obstetric team works very closely with us, and in fact they are 100% pro in making sure that these practices do go in and benefit every baby. The most fundamental thing in that, which we all love every baby to have got, is the mother getting a complete coverage with antenatal steroids. So these are a couple of injections which mothers received in as a IM injection, betamethasone injections. 2 injections are given, and provided this course is completed, there is a tremendously better chance that the baby's lungs are mature, the baby's skin is more mature, the heart is more mature, the brain is more mature, and there are lesser chances of breathing difficulty, bleeding problems in the brain like IVH, baby having better feeding tolerance, and overall survival rates are better with this single intervention. Likewise, magnesium sulfate is another injection, which we would, like those pregnant mothers who are likely to deliver their babies soon to definitely receive. This is again a very well evidence proven strategy that when given as an injection, as an intravenous injection to mothers, improves the neurological maturity and prevents some complications like developmental delays and cerebral palsy in future. And this is something that earlier used to be given for mothers with hypertension, for controlling hypertension and the risk of eclampsia. Now it has been seen that even when given in mothers with no hypertension who are at risk of developing preterm delivery, it definitely improves the neurological function of the baby. So these are some important interventions. And the other thing which we would really see happening more and more is such mothers, those who are high risk for preterm, even if they had begun to follow up in centers near their house where they may not have an extensive NICU facility. Just prior to the delivery, if the mother can be shifted with the baby in her womb and she can deliver in a high risk tertiary care center where, as ma'am said, you have the obstetric team, you have the NICU team who can take care of the baby right from the golden minute, then the outcomes of the pregnancy, the outcomes of the baby are much better. So would you like to talk a little bit more about this concept of in-utero transfer?
See, wherever possible, you should always, as a pregnant woman, you should always, with the help of the entire family, should judge the place of delivery, because the place of delivery is very, very important. it should address to the problem that you are having currently. If you have a smaller baby and you are anticipating preterm delivery, there is no point in delivering in a smaller center, putting the baby at risk of the handling and care that preterm delivery needs. There are lapses in the available neonatologist. If somebody is not there, what is the care that has to be given? All these things put the baby vulnerable to life risk. And that is why we always tell that the best thing that you should do is reach out to a center with at least a level 3 NICU, because those centers work with ethics, work with complete care, and work in a 24-bar situation where any moment anything happens, they'll be able to cover and give justice to the baby's life. And mothers who come with the baby for delivery have better outcomes, not only for them, because if there is any chance of having a vaginal delivery, we'll be geared up. If there is any chance of having a complex situation which needs intensive care, we are geared up. At any point in time, she might lose blood, we have a blood bank. She will not have to worry about all these things. They will be taken care. And in fact, with a safe delivery comes a safer outcome for the baby in terms of giving the baby the right neonatal care, and the unit is responsible for the baby's health. Now, in-utero transfer has gained lot of importance recently. Whatever said and done, how much ever the ambulance goes, the pediatric ambulance goes and gets the baby who is delivered there from their place to the level 3 NICU, all this is actually not required if the mother herself comes and delivers the baby in a better place, because that's the best and that has a better outcome. And given a situation that mother has no way to go and you had to deliver there, teams are geared up with the entire equipment to go and get the baby and give the baby a better survival. But I still feel that in-utero transfer is very, very important. And not only that, taking care of the mother, giving steroid, giving magnesium sulfate, improving the baby outcomes, closer monitoring of the baby by baby perfusion, placental condition, water levels by a fetal medicine team entirely changes the scenario, because fetal medicine teams are the ones who are actually the guardians of the baby, and they will give us the right time to deliver the baby. Then the outcomes are very, very good, and you will not have a bad outcome since they have been checked for, and we have been rest assured to wait a certain period or do it immediately. These kind of decision making is documented, evidence based, and they have very good results. And when it comes to the protocols are the core essence. Sometimes we when we're taking care of so many thousands of babies, we in fact see a trend, a pattern that can give a better outcome. In fact, we have our own defined protocols at times to give the baby a better outcome and give a better chance. So in such situations, the clinicians who are working 24/7 to give good outcomes are having greater freedom at a level 3 center for NICU and a high risk pregnancy care center. And these are actually at service of pregnant couples who are wanting to give the best to their baby. It is not for the sake of our own integrity that we have these centers. These centers are for public use and use at the appropriate conditions and appropriate times. And you have a tremendous responsibility of decision making to enter into situations that will give you the best of outcomes.
Let me also tell here a little bit about what happens in that golden hour in a high risk center, just to give a perspective. So when as a NICU team member, when we get an intimation that we are going to have a high risk or a preterm delivery, we gear up a whole team. So the team will comprise of at least 2 neonatologists, 2 skilled doctors who can handle intubation of a baby, starting the baby on the right respiratory support, giving surfactant if required, and we would be supported by at least 2 to 3 skilled neonatal nurses who would be able to assist us in this process. And there is a whole checklist of appropriate equipment or devices that we definitely ensure we have around. So it starts from the right environment. The temperature of the OT itself is ensured that it's more than 25-26 degrees. So we often switch off the air conditioning to make sure that when the baby is born, the baby is warm. And then we have the other checklist of equipment, starting from the plastic wrap. You would have probably seen somewhere that these babies are received in a polythene wrap, so that the water that is the amniotic fluid and the vernix caseosa that is on their skin is not removed, because in the process of evaporation they can also lose heat. So there is this plastic or a sterile polythene wrap. Then we have enough warm, pre-warmed linen to receive them. Wherever possible, the obstetric team tries to do delayed cord clamping in these babies if they do not need that immediate resuscitation. If they need immediate resuscitation, we are equipped with special ventilation devices. That is, instead of using regular ambu bags, what we say in the bigger babies, in the term babies, we use some special devices which are called T-piece resuscitator, which can give more PEEP or pressure to expand these babies' lungs, because their lungs are immature and they tend to collapse. And then we also ensure that we have a blender. A blender is actually a device which actually integrates air and oxygen to give very closely titrated oxygen levels in these babies, because we don't want to give them more oxygen.
Yeah.
So if you just give that plain 100% oxygen that you get from the pipe that we would have often seen for the bigger babies, these babies can develop eye issues, brain issues and lung issues, and hence from the very first second that they are born, we tried to put them on a blended air oxygen mix with very close monitoring of their saturations. So a pulse oximeter with a special baby probe. Usually we have a wraparound probe like a wristwatch for these small babies, which is used for checking their SpO2 or their blood saturation oxygen levels, and that is used for closely titrating how much oxygen concentration is given with a blender. And then the transition to the NICU also happens in a closed environment. In our unit, the delivery OT and the labor room are just beside our NICU, making the transit to the NICU so easy. So instead, if we had to go and bring the baby from a different center, of course we have a transport incubator and a transport ambulance, but we would lose a lot of time in actually transitioning these babies and bringing them to the NICU. And by the time they might have become cold, their temperature might have come down, they develop sometimes more breathing difficulty, and they may end up needing things like intubation and ventilation. So instead, when the transition is so quick and smooth, where we can start the right respiratory support within seconds, very often it is possible to manage these babies on non-invasive support, wherein we just give CPAP or non-invasive ventilation using a mask or a nasal prongs. So more and more in neonatology, we are now seeing that with the right delivery room care, that is when we start care early, we are able to avoid intubation, we are able to avoid invasive procedures in these babies, we are able to avoid infections in these babies and long hospital stays and complications. But for that, we have to really start early, and this early start is often called as the golden minute for these preterm babies. So the first 60 seconds translates into a better first day. A better first day translates into a better first week. A better first week in turn translates into a overall better neonatal course, and this in turn translates into better pediatric or childhood outcomes. So overall, what it emphasizes is, if we start early and if we give the optimal start, like by good temperature care, having the right temperature in the OT, by doing proper cord care, delayed cord clamping, and trying to give them a smooth transition, trying to avoid intubation, using blenders, using blended air oxygen, and trying to give non-invasive support like CPAP rather than intubation wherever possible, and starting them on the right respiratory support in the NICU. So all this, and ensuring good glucose levels, starting the enteral or the parenteral feeding within the first few minutes, all this, and using breast milk. Having a breast milk bank is such a big boon for a unit that is managing preterm babies. So what we do in milk banks is we kind of pool in breast milk from those mothers who are ready, who are willing for voluntary milk donation. And of course, they all go through appropriate screening during pregnancy. And once they are consenting for milk donation, their milk is expressed, it is pooled, collected and initially stored in a refrigerator. Then we pasteurize this breast milk using Holder's technique of pasteurization, where it is heated to 62.5 degrees for 30 minutes and then it is cooled rapidly. So there is a servo controlled pasteurizer that is there for this purpose. After this pasteurization, again we do quality checking by sending milk cultures, and milk cultures, if they are sterile, the milk is considered to be suitable for milk donation or dispensing. So this is then deep frozen until we require it for a baby. So when we require it, we thaw the milk, we rewarm the milk and then we dispense it or we provide it to the baby. And this is something that is done completely free of cost, without any sort of commercial intent put into it, because we all know as doctors that breast milk is actually like liquid gold for preterm babies. So it has been seen that giving breast milk and avoiding formula milk is associated with lesser NEC, which is necrotizing enterocolitis, lesser infections, better survival in these babies. And NEC is one of the problems we really want to avoid. This is a condition where the intestines may get infected and the baby is not ready to take in more milk. We may sometimes have to keep the baby fasting for a few days until the abdomen settles. So instead, giving human milk has been found to be associated with so many benefits, including better IQ and development in the long run. So ma'am, you have been a very integral part of a human milk banking. So how has been your journey with breast milk banking?
Breast milk banking is one of the most precious things that a preterm delivery mother baby can take care. See, I have my own experience where when my twins were born, at that point in time, I used to have extra milk other than for the twins that I used to give them. And it used to be useful for so many other mothers.
Right.
For them, they used to wait till my samples reach the hospital and then they used to divide that and use it for the other babies.
Wow.
At that point in time. Then I realized that it's really very, very important for somebody who's having a surplus. The point that should be taken is there's always a scope of donation. It's not blood, it's not money. There are certain things that are more precious than these two. That is human breast milk. And for some children whose mothers are not able to produce as soon as they deliver or in the transition from NICUs, sometimes the mother is detached to the baby. At that point in time when we really have to start something for the baby, mother's milk is the best milk. And the more closer that we are, if we can get a preterm mother's milk for the preterm baby, it's even more better.
Yeah.
And this needs a little more of going into the society and telling them that it's good that you are already screened. You know about your health condition. You've had a delivery.
Yes.
And you've, at least in pregnancy, we screen them twice.
Yep.
And once you deliver, you have a good nutritional status. When you're producing surplus, if you can donate that milk, then that's the best thing that you can do. And you will not only have so many good things to yourself, you will also be helping a newborn who's in need of mother's milk. We have seen so many stories evolve, get better and get discharged from the hospital, that every story inspires us to do a better job again and again and motivate more mothers for this good cause. And when it comes to prematurity, there is so much of stigma in the society that this weaker will not survive, that weaker will not survive. We have to break this silence and we have to break this misconception around prematurity that is not giving even good babies outcomes, because parents tend to listen to so many hearsay stories that they withdraw treatment. They don't go proactively for management. You have to talk about it.
Yeah. Thank you, ma'am, for actually bringing that very hot issue. I agree that there's so much of stigma and negativity that surrounds a preterm baby's birth. A lot of families get, advice and suggestions telling, why are you even pursuing the care of this baby? Baby is only below 1 kg, unlikely to survive. Even if the baby survives, baby may survive with a handicap, so and so on and so forth. What I would sincerely try to tell everyone listening to this podcast is this, and this I'm not telling because of a bias of being in neonatology now for 15 years, but this is based on facts. This is based on real data. If you see majority of the babies that are born at gestational ages 25 weeks onwards, and when I'm talking about majority, I'm talking about 90% of babies can survive with basic neonatal care, which includes 4 5 important pillars: human milk feeding, doing kangaroo mother care, skin to skin contact, preventing infections, giving the baby the right respiratory support, gentle respiratory support, trying to use CPAP, giving early surfactant, trying to avoid intubation ventilation wherever possible, or trying to extubate them from ventilator early, and last but not the least, doing a in-utero transfer or trying to deliver the baby in the setup where all the facilities including NICU and high risk pregnancy are available. As long as these are followed, what we see is majority of these babies will survive, can survive, and they can survive and lead normal lives, by which I mean that 90% of the survivors again will reach comparable IQ, will have comparable development milestones. They will catch up the milestones with their term peers based on their corrected age in follow-up visits. So it needs care. It definitely doesn't take away the care, the efforts, the family's involvement, the whole team's involvement, from obstetrics, from neonatology, from nursing, from lactation counselors, from physiotherapists, from all of us together, and from all of you as family. Of course, it's a whole team effort to see the baby go home healthy, but it is possible in the majority of the situations, provided there has been appropriate antenatal care, appropriate follow up during pregnancy, all the aspects that ma'am was talking about, like, early pregnancy care, appropriate nutrition, controlling the BMI, preventing other harmful risk factors like overnutrition, high blood sugars. These have been ensured. Mother has been covered with antenatal steroids and magnesium sulfate and given that right opportunity and right time for delivering the baby, and the baby is taken care right from the golden minute in a NICU, which has all the infrastructure starting from blender, CPAP, a team of qualified neonatologists. By team, I mean it's not a single person job. A NICU is teamwork, and it means you should have qualified neonatologists round the clock. It's not about having someone coming in from 10 o'clock in the morning and leaving at 2 o'clock and in the afternoon, and the rest of the time the baby is being managed by semi qualified people. That's not the way we can take care of small babies like this. It needs a team of qualified neonatologists who can handle any up
Round the
and
clock.
down round the clock 24/7, and this hand holding is needed for these small babies. And with all this, we are able to see excellent outcomes in our babies. Now we are seeing babies who have grown up to 10, 11, 12, 14 years. Those whom we have managed in this particular center alone would have reached around 6 to 7 years at least. And ma'am, I'm sure in her experience must have seen much bigger children who are now into teenage and adolescence. The families come back and say happily that thank you doctor for letting us take the right decision at the right time.
Because I still remember 24 years back when I delivered a preterm 1 kg baby in a peripheral center, where we just gave some warm care and support, and then some corporate hospital from Hyderabad came and took the baby back, and now the baby got married, and I have delivered their child also.
Wow.
So it is a story in itself, where 24 years back a 1 kg baby survived, and where are we right now?
Yeah.
Still they judge to give support for a 1 kg baby. Society is so harsh. There are so many gender biases that go on. And people who are just giving unwanted advice, they don't care whether that advice is going to make a real impact on the parents. When the parents are actually the most vulnerable time, these kind of negative thoughts given to them, God forbidden, from nowhere they come, and they just throw their ideas onto a vulnerable couple, they at times, take that decision and try to withdraw also. Again, it takes a hell lot of a support from our team to call them up, to talk to them and tell them to give the right opportunity. We tell them, and we actually, in fact, are not doing anything but repairing the trauma that they have been given by undoing the damage. It takes a lot of courage to undo the damage. And I even have a personal experience when my girl children were born, twins. They gave so many unwanted advices that it's only 800 grams, two babies, they might not survive, you're draining your finances, what is the point in supporting two girl babies together, you can as well put your resources on one girl baby. There's so many idiots, world is full of idiots, and they give unwanted information, and even without asking. So unwanted waste information comes even without any effort. So I tell parents out there who are literally having their precious babies in their hands, who are born preterm, you should talk to your obstetrician. Sometimes obstetricians also say that they might not survive. No, I am not correct at this point. Every obstetrician is not optimistic. You should talk to the neonatologist in a level 3 center, where they have the right outlook, perspective, knowledge, capacity and drive to give your babies home. Because you are the people who can actually describe their outcomes. It is not always the obstetrician, because obstetricians can have information, cannot have information. They might have those kind of deliveries in their setup, they might not have. Sometimes they do only low risk cases, so they might not be having an exposure. So it's always the level 3, level 4 NICU neonatologists who are in charge of explaining you the right outcomes. And you should give the opportunity to every child for survival, because that's the least that we can do. Because money comes, goes, but life doesn't. So life is definitely more important than any other aspect.
We are available and we are more than happy to be of service to such families. But again, all the people that they are surrounded by also should be supportive in the sense. Now, our job becomes very easy when the obstetrician is on board with us. When the obstetrician also says, yes, your baby can be saved in the right setup, and let's collaborate with the neonatologist. When that word comes from the obstetrician, it makes our job easy. When the family and the extended family is on the same page, it definitely gives the couple much better confidence. But again, it's all about giving the right information and seeking out the right information from the right person. Sometimes we too find that when the family is in this situation, they may call a doctor, but that doctor might not be from the neonatology or from the pediatrics
That's why
aspect.
I said
Yes,
no doctor's input, because every doctor need not be
a specialist in
situation analyst in neonatology.
Exactly. So even if we have an ortho problem, we should go and seek advice from an orthopedician. I mean, we can't treat ourselves when it comes to areas that we are not dealing with directly. So because our exposure and our knowledge within that domain will be limited to a textbook knowledge or what we may be able to read from a Google or Chat GPT.
Yeah, we would not be updating on the recent trends at
Exactly.
all, because we would be knowing our own subject. And it is always important, when you don't know certain things, you should keep quiet rather than spread negativity.
Yes.
Because one negative word multiplies in the patient's brain, and they keep processing it, because that might be a little easy situation for them to quit. See, to fight, it takes guts.
Yes.
To quit, it takes nothing. So, to save every preterm, it's a fight every day.
True.
It's a fight every day.
Absolutely.
Because NICUs can be overwhelming, they can be ups and downs, and there's never a straight line.
Yeah.
There's never a straight way. There are own ups and downs of prematurity in NICU when the baby is out
Correct.
rooming in.
Yeah.
And when the babies go home also, there are certain things that are very, very peculiar about newborn babies and full-term babies
Especially
and
the
preterm
preterm.
babies. Yes.
Yes. So talking about this family support, as you said, ma'am, rightly, it's an ongoing support that they need. Of course, they need lot of support at the time that they take the right decision, and then it's all about how they manage their everyday ups and downs. So talking about family-centric care and kangaroo mother care. So how do you support your patients or your pregnant mothers who have had a preterm delivery? Now, very often I find that families come and get an update from us, and then they would immediately go and seek out your suggestion, telling, "Ma'am, this is what the neonatologist told us. Apparently, baby is now on CPAP, and the baby is not tolerating feeding today. They tried to give milk, and this happened." So, how do you really support these families?
So basically, since I have a hands-on experience of NICUs from so many years, I generally tend to prepare them. Whenever they are even scheduled for a preterm delivery, I always tell them that preterm deliveries are special. You might see some fluctuations up and down. They might have a days which are very good, days which are very bad, days which are fluctuating in terms of baby's health, but they'll all come back to normal. All that is needed is patience for the first 48 hours. Do not deep dive into getting outcomes within that period of time, because the baby takes time. 48 hours minimum. You just have to maintain silence, and if there is anything important, the neonatologist will inform you. Make sure that you have people and resources that will fund the treatment, and also resources like getting blood products handy, and making sure that you encourage your wife and help her to do breast milk expression by giving her some comfort, and also the right diet and the right equipment for breast milk expressing breast milk, and encourage her to express breast milk on a regular basis every 2 to 3 hours, so that the output is maintained. And anybody with a negative attitude, just keep them away from the system. And for some babies who have been having chronic challenges inside the mother's womb, I would definitely tell them that feeding can be a challenge. Just hold on for some time. 1 week it can obviously take to establish and make sure that feeding happens. And don't rush for weight gain. Weight gain is a very slow process. If infections are not there, if the baby's general health parameters are good, you will eventually come there. And wherever possible, once the baby's weight increases, make sure that your presence is there. Even if the mother is held up with some other responsibilities, the father can come, give warm care and support. Kangaroo father care is also very important. Kangaroo mother care is also very important. And make sure that you are emotionally stable, because babies sense that emotional vibes, and babies understand what is going through within you, because they have that capacity. The more positive you are, the more positive results you can see there in the NICU. The more irritating and cribbing and negative thoughts that you have, even the baby faces that many challenges in the NICU. So it is not only a perspective that I have seen, it is a reality that I always explain everybody. You have to be optimistic. It costs nothing to be optimistic. And if you are optimistic, in fact, you're going to lower down on the unnecessary expenditure that you're going to spend on complications being wild at times. So it's a journey, and it's a fixed journey. For somebody who delivers at 26 weeks, you anyways have to be there in the hospital till 34, 35 weeks. There's no doubt about it. Then why ask after 20 days, when are we going to get discharged? That's stupidity. That's a question that is actually not supposed to be asked. And when your baby is getting the care, love, affection, warmth, we call it tender loving care from you, and the attention from the NICU,
Nurses.
it's obviously the baby's duty to recover well and go home. In spite of knowing this, they are not happy with that happiness.
Right. So there are a lot of things that we too try to do to allay the anxiety and stress for parents. We are of course extremely aware and sensitive to the fact that it is a little stressful. It is a little I would say financially, sometimes intellectually draining journey to go through a baby who's in the NICU, especially for a few weeks and some long duration of time that occasionally these babies do need. Like a 26-weeker might stay in the NICU for 8 weeks. Now, things that really help the families, which I've seen, is one, we try to be transparent in our counseling. So there is no kind of trying to keep some information from the family, because the family has every right. They deserve to know exactly what is happening, and we have no filters while talking with the family. We give the update as it is. At the same time, there is also a certain anticipation or a certain reassurance that comes in every step. So when we say, see, today we have decided to continue ventilation for another day, we will definitely also update you as to what is our tentative plan. So we may tell you that, okay, today the baby is still needing ventilation, but we may try to remove the baby from ventilator tomorrow, and we may try to go to non-invasive ventilation or to CPAP. So there is always a plan that we make, but of course these plans will have some tweaking as they go based on the real time status of the baby. Now also there is a duration of time, as ma'am said, that we will need to spend in the hospital. So we always try to give a realistic figure as to what will be the tentative duration of discharge. We also try to say that this is roughly the duration baby may need some breathing support. This is the time the baby may need to reach full tube feeding. This is the duration of time that we may be able to start breastfeeding, and so on. The other things that really help are the family's involvement in the care. So we always see that when mothers come in and spend more time with their babies, when fathers come to visit the babies, and when both of them are able to spend some time together, maybe just holding the baby's hand, maybe just doing kangaroo care. Both mothers and fathers can do kangaroo care. We encourage all our parents to do kangaroo care as long as they can spend in the unit, and just coming and trying to be with the baby, touching the baby, maybe just giving gentle pats on the baby, and trying to participate in regular baby care, things like diaper changing or holding the feeding tube while giving a tube feeding, just trying to hold the baby, or indicating when the saturations, or when the temperature probe or the saturation probe need to be changed. We can teach all these small things to mothers, which they can actually participate, and most of them feel very good in doing this. We also have family centered care ICU rooms, where mothers and families who are interested to spend longer duration with the families, with the baby, can actually take a room when the baby is reasonably stable, of course. So the baby can be moved to to kind of a private space, where there will be a NICU nurse, there will be monitoring equipment, there will be a warmer, and the mothers can just be stationed right next to their baby. So this gives them the feeling that the baby is almost nearing the stage where the baby can come home. The baby is just getting simple care, like maybe a humidified a nasal cannula gas, or the baby might just be on tube feeding while the baby is transitioning to the journey of going home. So all these things, and of course kangaroo care, having a very transparent discussion, telling them what is happening, telling them what is anticipated, I think goes a long way in helping families understand where we are and where we are going to go in the next few days. It also prepares them for the journey of becoming hands-on parents, which they are going to get over the next few days, and preparing them for the follow-up. So in terms of, ma'am, these simple things, I think you always support us and try to help families understand about the good things and the bad things, and how do we prepare them for discharge. I mean, as an obstetrician, when these babies go home, again they would come and ask you, ma'am, like, well, we are going to go home, we are a little scared. So how do you really prepare them for that stage?
Whenever they have longer journeys in NICUs, they keep coming to the hospital and they keep talking to us, and we reassure them that everything is going to be fine. And when they actually get shifted to the family centric room, that's when they come back and tell us that now we have been shifted to the family centric room, we're going to take the baby home. They would definitely ask us some tips, that how did I manage, or how well that their capacities and all that, since we know them for a very long time. I always tell them babies need warm care. So temperature is something that you should look at, and avoid attenders, avoid relatives coming home, and avoid going to public places because you might get something to the baby home. So that is something very, very important. And feeding techniques are really, really the core. So if you're feeding the baby very well, you practice it in an NICU itself, and family centric room also we practice. The mother actually practices, and she's the one who's giving the care. And once she's hands on, we always encourage even the father to give the feed, so that the mother is not only the person who's going to get exhausted, because these smaller babies need a longer time of feeding. That's very important. And if grandparents are there, we also train the grandparents for that purpose, and making sure that you watch for signs that can be problematic and you reach out to the hospital. Since we are 24/7 high risk obstetric care and neonatal care with qualified people in the hospital taking care of labors and deliveries and smaller babies, so they can reach out to the hospital at any given point in time. Minor issues, we are always there online in WhatsApp groups supporting them and giving them advice. But they should have confidence, and they should believe in themselves, and not only believe in themselves, they should also be positive in their outlook, and they shouldn't be nervous. Any nervousness will trigger unwanted complications and problems, and it can be sometimes very overwhelming also, the baby going home, and some people would want to come and visit the baby immediately. I would definitely say, unless and until the baby reaches say about 4 or 5 kg, you should never allow public appearances for the babies, because it's very, very important. They are vulnerable for infections. And the care also should be important at home, because they have sensitive skins. Correct. You cannot be using wild lotions and everything, and massages. All these daily home care should be just kept aside. And until and unless
people to just massage the baby,
until and unless your baby reaches 3 kg plus, you should not be giving the baby regular baths also. That is also very important. It's tepid sponging and taking care of the cleanliness, and gentle skin care is important. Yeah. And we have so many chemicals in the products that we are using right now, including their clothes that they wear. We shouldn't use harsh disinfectants like Dettol and all. You should use organic, soft disinfectants without any chemicals. And clothes also, I generally suggest clothes which are not chemicals and colors and all that.
Natural fibers.
Yeah, natural fibers, some soft linen or muslin, or organic dyed clothes, or no color clothes, and nicely wrapped up properly and kept in a safe zone. Babies don't need high-tech things, like cribs and all these things. Absolutely. They just need good clean spaces.
Yes.
Clean spaces with good ventilation and light.
Absolutely agree. I think in this context, there are a couple of innovative Indian made actually devices also that I just wanted to mention. So we have these temperature sensing watches that are now available also, that we can actually put like a small wristband, and that kind of gives a beep when the baby's temperature goes down. So we can go up and see whether the room is cold or the baby just needs to be wrapped up better, or mom can just give KMC and the baby's temperature will improve. We also have very nice apnea alarms which can just sense when the baby is kind of going into a little bit of slow, shallow breathing, and someone can stimulate and make the baby wake up a little bit, because babies still have this shallow breathing and going into little weak respiratory drive for some weeks. And there are certain other follow-up visits that we generally talk to the families about. Particularly, there is a retina screening that these babies should, ROP screening that these babies should miss. hearing, and then there is a brain scan that we do a few times during the NICU, maybe 2 or 3 times, and then we generally do one more at 40 weeks, because these are all things to ensure that the baby is nicely screened for. And all these regular screenings are so essential to ensure that the baby doesn't have complications. Particularly the ROP visit is something that one should not miss, because it's important to make sure that the retina of the baby is nicely developed. Because now if we identify these things early, again there is nothing to get worried and anxious about it. There are excellent therapeutic models starting from laser and intravitreal. We have these VEGF antagonist drugs like bevacizumab that, when given, the process of inappropriate vascularization actually stops and the baby can start having a normal retinal growth. And we also need a regular follow-up, neurological follow-up for this baby. So we have a neonatal follow-up clinic model where a team of we have a developmental pediatrician, we have the neonatologist ourselves, and then we have the early intervention therapists who all work together. And starting from term age, that is from the 40 weeks or the actual delivery date, and then moving forward every 3 months, the babies are assessed for the follow-up, where the neurological examination, muscle tone, these are all checked, and early deviations can be identified and can be addressed. And majority of these babies, even if they have these subtle lags initially, they eventually catch up and they have normal outcomes. So ma'am, I think it's been a wonderful discussion, and I think we have emphasized on this very important message that for having a healthy baby, we need a healthy beginning, and that comes from a healthy mother, and that in turn comes from a healthy woman and a healthy girl child. Yes. So it's like a life cycle concept where a healthy adolescent girl becomes a healthy mother, and she has a healthy baby in her womb, who in turn, when given the right care from birth, can translate into a healthy child. Ma'am, your final messages for our listeners.
It's very, very, sentimental for me in terms of preterm, discussion. But I always say that in this chaos of the world, where women are equal, competitive, they are delaying motherhood, and they are having a lot of ups and downs in their life, irregular timings of work, where they have problems in diet, problems in managing their own health, and overweight issues, where sperm quality is also gone very, very bad these days. We are having issues with the babies in terms of early miscarriages, then sometimes very early preterms, placental problems. We have unknown problems of diabetes implications on the newborns, and we have, God forbid, a lot of problems during deliveries also. All this translates to one point, that wherever given a choice, health is something that every woman or man should concentrate on. And it is important because your choices define your reproduction. Your choices define your wellness at 40s, 50s, 60s. Your choices define whether you will live, nourish yourself and your body and your family, or will have an abrupt ending and a death which is not warranted. Your choices define your entire perspective and your life. And I always ask people to have healthier choices. That's why preach and practice holistic living, because that is the essence of life. And when you have good ethics and holistic living around yourself, you will always have better outcomes and manageable outcomes and predictable outcomes. There will be no question of unpredictability there. So this is something that I want to really give the community, that take care of your health and your 360-degree wellness. You might be physically well, but you might have challenges in your thoughts, and you might have anxiety issues. All these can translate into sleep issues and overall, again, health issues. So it's 360-degree holistic care that you should be taking care of yourself and address to both physical and mental problems equally, and make sure you define health as a holistic wellness, both physical, mental, social, and emotional well-being, and just not an absence of a disease of infirmity. So this is a WHO definition of health, and I request everybody to the best of their health so that we will have lesser challenges to take.
For us to take.
Yes, and give better outcomes even if you have unpredictable outcomes, because there are certain problems there where you cannot prevent preterm, like uterine malformations and all. We cannot prevent preterm. If you have a triplets, we cannot prevent preterm. So like that. So there are certain situations which cannot prevent preterm, which cannot prevent obstetric challenges. Rest all where you can prevent, please look into those angles.
So on that note, I think we wish everyone out there an extremely healthy life ahead, and whenever you do plan pregnancy, a healthy pregnancy and
Yes.
healthy babies.
Preconception is the beginning.
Yes, preconception is the beginning. Planned pregnancies are always better, and planning at the right time.
High risk centers always will do a better job for you. We'll be watching out for preventing problems and give you the apt treatment wherever possible.